Welcome to the debate. Today, we're opening a file that I know is sitting on the desks of many of you listening right now. We are looking at the convergence of ancient contemplative wisdom and the front lines of modern clinical psychiatry. Specifically, we're examining the intersection of Buddhist psychology and the treatment of obsessive-compulsive disorder.
It's a heavy topic and a necessary one. And I think for the mental health professionals in our audience, we're not talking about mindfulness in the watered-down corporate sense, take 3 breaths and feel better. We are digging into the heavy machinery of the Dharma and how it aligns, or, well, perhaps conflicts, with the Western medical models we use every day.
Exactly. The central question we're wrestling with today is really one of depth and clinical function. Does Buddhist psychology serve primarily as a supportive framework, a kind of wisdom layer, if you will, that helps explain why gold standard treatments like exposure and response prevention work? Or, and this is the key, does the specific treatment of self-concept OCD require a much more radical philosophical deconstruction of the self, something that our Western modalities often overlook?
To put it in terms of the therapy room, are we giving the patient a better shield to protect their identity, or are we trying to show them that there's no one standing on the battlefield to be hit in the first place?
That is a vital distinction. So to explore this, we're drawing on the academic work of Naomi Matlow, particularly her thesis, A Thought is Just a Thought, which aligns the Noble Eightfold Path with OCD recovery. And we're contrasting that with research from Adam Brandt and Laura Smestead on Self-Concept OCD and their application of the doctrine of Anātta, or no self.
And I'll be taking the position that for specific, identity-threatening forms of OCD, what we're calling SCOCD, standard behavioral tools are just insufficient. I mean, true relief requires that radical ontological shift of no self. As clinicians, we have to help the patient resolve the crisis of personhood, not just habituate them to anxiety.
And I'm going to argue that Buddhist psychology provides the essential architecture for mental hygiene, specifically through concepts like the sense doors and the Four Noble Truths. It explains the why behind the clinical how, making tools like ERP effective for all OCD sufferers without requiring them to, abandon their sense of identity entirely.
Well, let's get into the structure of it, because I think we agree that the current tools are powerful, but we disagree on their reach.
Right. I want to start with Matlow's primary assertion, which I think is brilliant for psychoeducation. She frames the Buddha effectively as the original cognitive scientist. If you look at the Four Noble Truths, they aren't just religious tenets. They map almost perfectly onto the Western medical diagnosis model that, every clinician knows.
Walk us through that parallel, because I think it frames your position really well.
It's just straight clinical logic. First, the first noble truth, dukkha, there is suffering. In a clinical intake, this is the diagnosis. The patient presents with symptoms, intrusive thoughts, anxiety, the whole loop of compulsion. They are in pain. Second, the second noble truth, samudaya, the cause of suffering is tanha, or clinging.
The craving.
Exactly, the craving. In OCD terms, this is the desperate need for certainty, the craving to the anxiety to stop, the grasping for control.
Which, of course, inevitably leads to the compulsion, the behavioral attempt to satisfy that craving.
Exactly right. Then the third noble truth, nirodha, cessation is possible. This is the prognosis, recovery is achievable. We aren't stuck here. And finally, the fourth noble truth, the path to cessation is the Noble Eightfold Path. This is the treatment plan. Matlow argues this isn't just a metaphor. When a clinician understands this structure, they aren't just treating a disorder, they're addressing the fundamental human mechanism of attachment. It universalizes the patient's struggle.
It is a compelling structural argument, I'll grant you that. It certainly helps depathologize the experience for the client, but the treatment plan, the Eightfold Path, that's where the friction starts. Matlow emphasizes right view and right mindfulness as the heavy hitters here.
She does. And specifically, she brings in the concept of the 6 sense doors. This, for me, is the game changer, and I think for any clinician working with intrusive thoughts. In Western psychology, we privilege thinking. We treat thoughts as these heavyweight special events that define our internal reality. We say, I think, therefore I am. But in Buddhist psychology, the mind is just the sixth sense door.
It's just a scanner.
Precisely. The eye sees visible objects, the ear hears sounds, the tongue tastes flavors, the mind cognizes thoughts. That's just its biological function. So Matlow argues that the primary clinical breakthrough lies in recategorizing thoughts as merely intellect medium events. If a clinician can help a patient view the mind as just another sense door, then an intrusive thought about, say, contamination becomes no more significant than a bird chirping outside the window or the smell of coffee. It enters the field of awareness, and if we don't cling to it, it exits.
This supports the mechanism of exposure and response prevention, ERP, quite well, I'll grant you. In ERP, you expose the patient to the fear and you prevent the ritual. So if I treat the thought as a sound, just noise, I don't need to perform a ritual to fix it. I don't argue with a car horn, so why argue with a thought?
Exactly. We aren't fighting the thought. We're recognizing it as a physiological event that doesn't belong to us. It supercharges the behavioral therapy by removing the emotional weight of the debris. It gives the patient a place to stand where they can watch the show without being on the stage.
Look, that logic holds up beautifully for what I would call classic OCD. Washing hands, checking locks, arranging symmetry. If I think my hands are dirty, I can observe that thought as noise and not wash. However, I am not convinced by that line of reasoning when we step into the territory Brandt and Smestad identify as Self-Concept OCD, or SCOCD.
Why should the mechanism differ? Clinging is clinging, whether it's about germs or identity.
Because the stakes are different. We aren't talking about germs or open doors. We are talking about the self-concept. These are patients plagued by ego-dystonic thoughts, thoughts that are repugnant to their core identity. What if I'm secretly a pedophile? What if I'm a violent psychopath? What if I want to hurt my family?
But isn't the distress still caused by the clinging? They're clinging to the idea of being a good person.
It's clinging to identity, not just safety. Brandt and Smestad argue that for these patients, the intrusive thought threatens the core definition of who they are. It creates a psycho-spiritual gap. ERP teaches you to sit with the anxiety, sure, but it fails to answer the patient's desperate, screaming question, who am I? If I can think this, who am I?
So you're saying behavioral tolerance isn't enough because the existential wound is still open?
I'm saying it leaves the self intact as a target. If I still believe I am a solid, defined entity, a good person, then a thought that says, you are a monster, is an existential threat. It's a missile headed for the control tower. Standard behavioral tools are insufficient because they're trying to protect a fortress that is under siege. So the only effective antidote for SCOCD is the specific application of Anātta, or no self. We have to move beyond just noticing thoughts to fundamentally rejecting the Western notion of a rigid, definable self that needs protecting.
Okay, that brings us right into the core of the debate, the mechanism of detachment. You're suggesting the self is the problem, whereas I would argue the relationship to the thought is the problem. Matlow cites the 4 R's utilized by Jeffrey Schwartz: relabel, reattribute, refocus, revalue.
A classic framework in the field, yeah. Many of our listeners probably use it.
It is classic for a reason. Matlow argues that relabeling, saying, it's not me, it's my OCD, is essentially the Buddhist practice of recognizing delusion. Delusion is one of the 3 unwholesome roots in Buddhism. If a patient sees the mind as that sixth sense door we discussed, they can watch a thought enter and exit like a visitor. This breaks the thought-anxiety-compulsion cycle. You don't need to destroy the concept of the self to do that. You just need to realize that the debris floating by isn't yours. It's just mental weather.
I'm sorry, but I just don't buy that for the SOCD patient. Relabeling is a cognitive trick, but does it hold up when the internal terror is existential? Brandt and Smestad offer a metaphor that I think dismantles the sufficiency of simple relabeling. They talk about the pool versus the stream.
I'm familiar with it, but walk us through the implications for the clinician.
Okay. In the Western view, and arguably in the way many patients use the 4 R's, the self is a pool. It has rigid boundaries, concrete walls. It's a container. This is how most of us see ourselves. I am this collection of traits inside this body.
If a leaf, or in this case a graphic intrusive thought about violence, falls into the pool, what is it? It's pollution. The pool is dirty. The patient frantically tries to fish it out to clean the self.
And you're saying relabeling is just pointing at the leaf and saying that's a leaf, but the leaf is still floating in the pool.
Exactly. The patient still feels contaminated because the container is static. They think, okay, it's OCD, but it's still in me. Brandt and Smastat argue we need to shift the metaphor to the stream. A stream has no rigid boundaries. It's integrated with the environment. Debris flows through it. It doesn't get polluted because it doesn't hold anything. It's a process, not a tank.
So the therapy is about changing the container.
The therapy must change the concept of the container. Yes, not just label the content. If I am a stream, the thought isn't not me, it's my OCD. The thought is just passing phenomena distinct from a me that doesn't really exist in the solid form anyway. You can't pollute a process.
That is a compelling argument, though I would frame it differently. The transition from pool to stream is actually what I mean by right view. I agree that analysis is a trap. Maslow points this out by referencing the cognitive distortions found in CBT. But right view isn't about ontological nihilism, believing we don't exist. It's about understanding that the phrase, "we are what we think," is a warning about clinging, not an endorsement of thought content validity.
Go deeper on that. How does right view stop the patient from analyzing the thought? Because that analysis is the fuel for the OCD fire.
Well, Thich Nhat Hanh talks about keeping the sun of awareness shining without fighting the mind. When we utilize the 4 R's correctly, or when we use Maslow's approach to the sense doors, we aren't trying to clean the pool. We are realizing the pollution is an illusion caused by our judgment. We don't need to dissolve the self entirely. We need to dissolve the judgment of the self. If I utilize right mindfulness, I'm simply aware of the thought's birth, duration, and dissolution. I don't need to verify if the thought is true because I understand the nature of thoughts is transient.
But here is where the inward turn, a term Carey uses and Brandt cites, becomes dangerous in a clinical setting without the Anātta framework. Even well-meaning therapists often fail SCOCD patients by trying to explore the meaning of thoughts. They say, let's look at why you had that violent image. What does it represent about your repressed anger? That validates the obsession. It tells the patient, there is something in the pool worth looking at.
Oh, I agree completely. Absolutely. Matlow is very clear that analysis is a trap. It feeds the cognitive fusion. We should never be digging for meaning in the garbage dump of intrusive thoughts.
Right, but why is it a trap? It's a trap because the patient believes there is a rugged individual inside them, a core truth that is being revealed by the thought. The Buddhist framework is superior precisely because it treats the self as a flexible environmental integration. As Mark Epstein puts it, we exaggerate our reality. The goal isn't to fix the thought. The goal is to realize there is no thinker to be implicated by it.
Meaning, if there's no me, there can be no potential killer inside me?
Precisely. If there is no fixed me, the obsession loses its teeth immediately. The self is just a construct, so the threat to it is null and void. The nightmare requires a dreamer. Wake up from the concept of the dreamer, and the nightmare is just pixels on a screen.
I see the utility in that, but I worry it's too abstract for a patient in acute distress. You don't exist can be a terrifying concept for someone already feeling mentally unstable. It sounds like depersonalization, which is a symptom we try to treat. Let's look at the 4 foundations of mindfulness, specifically the 3rd foundation, mindfulness of mind. This is a practical, workable tool that doesn't require a philosophy degree. Matlow describes turning the battlefield of the mind into a space of observation.
Observation of what, though, if not the content?
Of the quality of the mind. Is greed, hatred, or delusion present? By labeling the state of mind rather than the content of the thought, the patient creates distance. It's not I am evil, it's delusion is present, aversion is present, agitation is present. This objectifies the experience. It doesn't require the patient to grasp the metaphysical concept of Anātta right away.
It just asks them to step back and observe the machinery working. It turns the subjective drama into objective data.
That works for the mechanics, and for emotional regulation it is key. But again, I have to highlight the specific suffering of SCOCD. It's ego-dystonic. The thoughts are in disharmony with the self. Brandt and Smysdad point out that standard acceptance, which modalities like ACT promote, is nearly impossible if the patient still believes in a feared self.
The feared self being the version of them that might act on the thought.
Yes. If I believe I have a true self that might be a monster, I cannot accept the intrusive thought. I must fight it. Because if I accept it, I might become it. The no-self doctrine is the only thing that dismantles the feared self entirely. If I accept that I am a process, a stream, not a static entity, then a bad thought doesn't predict a bad future. It's just debris. The Anātta perspective removes the stakes of the game. You can't lose a game you aren't playing.
But isn't that essentially what acceptance and commitment therapy ACT aims to do? Matlow defends the compatibility of ACT and Buddhism vigorously. They both aim to move from cognitive fusion, where the thought and the reality are stuck together, to values-based living.
ACT is the closest Western cousin, I grant you that. It does heavy lifting in this area, but it often stops short of the full ontological shift.
I disagree that it stops short. I think it makes the shift accessible. Matlow quotes Suzuki Roshi, giving the cow a large, spacious meadow. We allow the thoughts to exist without engagement. That doesn't require a full philosophical conversion to Buddhism. It requires a shift in attitude. We give the cow room. We don't try to kill the cow. The ACT model of self as context, the observing self, is a bridge to Anātta without the religious barrier. It teaches the patient to be the locus of observation rather than the observed object.
It is a bridge, yes, but I worry about the secularization stripping the medicine of its potency. Olson uses the flypaper analogy: the more you wrestle with the self, the more you get stuck.
We both agree wrestling is bad. That's universal in this field.
Yes, but why do we wrestle? Because we think the flypaper is us. We think the stickiness is our soul. Brandt and Smysdad suggests that for SCOCD, the therapist must guide the client to accept that thoughts do not necessarily have to have any meaning. That is a radical departure from most Western meaning-making therapies. ACT gets close, but Anātta drives it home. If the self is empty, inherently empty, then the thoughts are empty. They aren't just not mine, as in they belong to the disease. They are not mine, because mine is a grammatical fiction. That is the liberation.
I think we're looking at two sides of the same coin, but the practical application matters. Maslow's focus on the Noble Eightfold Path, specifically right view and right mindfulness, provides a comprehensive architecture. It's not just about the moment of the thought. It's about navigating the 8 worldly winds: praise and blame, gain and loss, pleasure and pain, fame and disrepute.
Which creates resilience, absolutely. It creates a robust structure for living that goes beyond symptom management.
It reduces the suffering caused by the illusion of control. The sense doors model demystifies the scary thoughts. It turns a demon into a neurological event. That is empowering. It allows the patient to reclaim their life now, utilizing the tools of ERP, but supercharged with this wisdom. We teach them, you are the sky, not the clouds.
And I maintain that for those specifically plagued by questions of identity, the SCOCD sufferers, that empowerment is incomplete without the key. The specific doctrine of Anātta unlocks the cage, because it reveals the cage was never locked. It renders the threat to the self obsolete. You don't need to protect a fortress that doesn't exist. The sky doesn't just hold the clouds. The sky implies an openness that cannot be harmed.
We certainly agree on the pitfalls. Analysis is a trap. Reassurance seeking, asking the therapist, am I a bad person, is a compulsion.
Absolutely. And we agree that the witnessing perspective, as Ram Dass puts it, is crucial. Everything changes when you identify with the witness instead of the actor. The witness is never afraid.
And Matlow and Brandt both converge on this. Suffering arises from the response to the thought, not the thought itself. Whether we call it clinging or identifying with the pool, the mechanism of suffering is the attachment.
True. The friction comes from the resistance.
So, to the clinicians listening, the question becomes one of calibration. Are we using Buddhist psychology to simply quiet the noise within the existing structures of the self? Are we using the Dharma as just another coping skill in the toolbox?
Or are we inviting the patient to fundamentally reimagine who is listening? Are we cleaning the pool, or are we showing them the stream? That is the challenge.
A profound question for practice, and one that suggests our work might be deeper than just symptom reduction. Thank you for joining us on The Debate.
Thank you. It was a pleasure.